Hey everybody, welcome back to the Gait Geeks. I am Scott and I'm joined with Ivo, and today we are again going to be revisiting one of our favorite topics, and it's plantar fasciitis. So hopefully this will be something that is of value to you, and we're going to get into it in just a second. So stay tuned. So, like I said, today, Ivo and we're going to be talking about plantar fasciitis. And I think the first question we really need to just jump right into is, are we saying the right thing by calling it plantar fasciitis? Is it truly an inflammatory condition, Ivo?
Maybe, and maybe not. The research is pointing to it's more of a degenerative condition rather than an inflammatory condition. See if I can find the paper that we had here.
Oh, are we talking about this one?
It's not that one, but that we can talk about that one. It talks about it in that particular paper. This just talks about mechanical treatment for plantar fasciitis, and that's what we're going to kind of be talking about this evening. Some of the various things that we have out there. So let me just get to risk. Yeah, here we go. Lamont, American Journal of Podiatry, talking about the histological findings, and basically that it's probably more degenerative than inflammatory, and that makes a lot of sense if you think about the origin. I think it was you that was telling me you kind of classify plantar fasciitis into two different categories. Why don't you go into that, and then we'll talk a little bit about what the plantar fascia is and its attachments, and then we can go from there.
Sure. So, in my world, I tend to see plantar fasciopathy or plantar fasciosis or plantar fasciitis, depending on how you want to classify it again, in two different categories, two different buckets. I see it in the really cavus type of foot, and I see it in the other end of the spectrum, which is a really pes planus or hypermobile foot. I tend to find that each one of those different cases responds a little bit differently to various types of treatments. For example, the rigid pes cavus type of variety of plantar fasciopathy tends, in my opinion, to respond better to things like night splints, tends to do better with things like passive stretching, manual mobilization, soft tissue mobilization, really working on increasing extensibility of the plantar fascia using the windlass mechanism, really diving into the talocrural joint, trying to get some more dorsiflexion. Orthotics have some benefit in dispersing forces, but in the other variety, which is the hypermobile variety, that's where I feel like adapting or manipulating the structure of the foot to a more neutral type of position, offloading that tissue, preventing that calcaneus from going into excessive eversion, preventing that navicular bone from dropping and having that arch collapse significantly. Those tend to do better with foot strengthening and, like I said, orthotic implementation. So those are the two buckets I like to utilize. And I was discussing it a little bit before with you, Ivo, about my analogy with the rigid type. I liken the plantar fascia to like a hammock, right? That's bound and tied up to two different trees, right? Tied or anchored to two different trees. And if you wanted to jump up and down on that hammock, there's a lot of load going through the hammock, but most of the load actually comes through the attachment points, which is what we would
Mhm.
classify as the medial tubercle of the calcaneus, or the origin of the plantar fascia. And that's where most people's symptoms tend to lie. Like when we talk about the symptoms of plantar fasciopathy or plantar fasciitis, you tend to complain about pain first thing getting out of bed, right? You know that those first couple of steps are usually the most uncomfortable, and that's where the night splint comes in, because when you're using a night splint, you're not allowing your foot to rest and relax for many hours during the night in this relaxed position. You're actually keeping it in a semi-stretched position, so that that first step in the morning, or that first, second, third step in the morning, isn't as drastic of a change from what you've been dealing with all night long. So what happens is, if you don't have that night splint and you take those first couple of steps, it's real painful. You really kind of rip apart all those bonds that your body's been trying to kind of work on healing all night long. And then the process never really gains any kind of any headway, because you're always undoing the work that your body's trying to do each and every night. So I know I kind of went on a bunch of different riffs there, but that's kind of how I kind of see in my head plantar fasciopathy.
I agree. That um, pain along that medial calcaneal tubercle is really big, and in fact, 45 to 80% of people will have a heel spur, a traction spur. Now, that doesn't mean because you have a traction spur, you have plantar fasciitis, but a lot of times when people have plantar fasciitis, they have a traction spur. Did that cause the plantar fasciitis? No. That's enthesopathy, which is secondary to stress. And again, that's going to depend upon where that stress is coming from. With the rigid cavus type foot, that's usually a lack of ankle rocker or ankle dorsiflexion that's occurring that.
Mhm.
And then as we rock forward from mid stance into terminal stance and pre-swing, and we have to dorsiflex that first MTP, that's going to tension that fascia to a greater degree. And when we do that, it's going to yank on that medial aspect. Now, if the fascia is somewhat looser, then all that stress is going to get forced into the intrinsic musculature, largely abductor hallucis, but also flexor hallucis and some of the others, which
Mhm.
can, flexor hallucis brevis, which can cause some of that. Um,
You made it great, but let me just stop you real because you made a great point about the traction spurs, and that's how I identify them. They're traction spurs. They're the body's response to the pulling on it, right? So
yeah.
oftentimes, some people will go to see a physician, they'll get an X-ray, and they'll see this spur, and they say, "Oh my God, that's why I have pain because I have this spur. I need to have this bone spur removed in order for my pain to go away." And it's you couldn't be further from the truth, in my opinion. That traction
Right.
spur is moving more in a, we'll call it, in a parallel direction with the plantar fascia, as opposed to being something that sticks down into the ground and you're walking on every step. So that it's very, 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 very unlikely that if you go in there and have that spur removed, that will decrease your pain. It's a result of the pulling and the pathology that's showing up on an X-ray, but it's not the cause of the pain.
Well, right, and a lot of people have them removed, and they still have plantar fasciitis.
Correct.
So yeah, it
And that
actually
spur will just
goes.
come back.
They really do. So here's a picture of the plantar fascia. Kind of on the bottom of the foot. It can be filled in some of these areas where you see it between the strips, which basically look like long flexor tendons in that area. The big things to remember about the plantar fascia is it's two layers: superficial layer, which is very flexible and can move around a lot, and then a deeper layer. That's the deep layer, which goes down and attaches to the underlying musculature, sometimes tendons and ligaments in the foot in that area there. So it's the deeper layer that's the one which often is causing the inflammatory condition. The superficial layer has a lot more elastic tissue in it and allows for a lot more movement there. There's going to be some thickening that we're going to see of the plantar fascia medially and laterally, and that's largely because of the pronatory and supinatory motions. We want ligaments are going to develop to kind of like bones along lines of stress, and you're going to get thicker things in the areas where we have the largest line of stress. And then I haven't seen this in the literature, but it's just kind of an observation as far as with palpation. When you have people that have toes which are curling under, which we've talked about when we talked about the quadratus plantae and stuff, people tend to have more plantar fascial thickening medially than they do laterally because of this, because of the increased stress as the foot coming underneath. And that's strictly from palpation. I don't generally dissect people's feet in the office, although there's a few people I can think of that I'd like to do that to, just to take a look at their foot. But just so we understand, there's these little slips that go out to the digits. It blends right with the tendons and the fascia. So when we do dorsiflex the toes, it is going to tension that fascia and create some of that traction that you were talking about. If we have a rigid cavus foot, then there's no place in the foot for it to take up the slack, and we're going to have a tendency to see that spur somewhat more. When we have a foot that's relatively flat, or pes planus with a lot of hypermobility in it, I haven't seen a lot of those traction spurs occur in that.
Hmm.
And what's happening is you're just getting the musculature, usually tib posterior, but a lot of the other muscles which are going to take up that. And we talked about that in our posterior tib talk,
Correct.
as far
Mhm.
as just when we see that, if it kind of goes beyond the fascia is already stretched at this point. So the burden of onus becomes on the musculature. With that all being said, this paper that you can bring that up, Scott, that would be great.
Sure.
That we were looking at was interesting. This came out in 2020, and it basically looked at a bunch of different mechanical means for treating plantar fasciitis. The important takeaways from the paper, and you can go and read it. It's a free full text. It's not a great paper. It was a meta-analysis. So they looked at almost, what, 50 papers or something, Scott?
43 made the
40,
final cut. Hmm.
43 papers, which covered a lot of different patients, a couple thousand patients. I
Hmm.
mean, they looked at all different sorts of things. The ones that they looked in here are like full length insoles, heel cups, night splints,
Taping.
rockered shoes, regular shoes, taping. And they wanted to compare, like, well, how do these things go and what does the literature really show with that? And the bottom takeaways that I took away from it, and you can certainly jump on this, Scott, were: one, combined therapies work better than singular therapy. So it wasn't like one thing alone really worked the best. It was when you combine things. Taping provide great short-term relief, not really long-term relief. Full-length insoles were better than just heel cups. The heel cups were basically cushioning, but you're cushioning something that doesn't need to be cushioned in a vertical direction. It needs to be cushioned in a horizontal direction. And that's probably why that wasn't working there. And then they were talking about rockered shoe, which basically eliminates the need for your plantar fascia to kind of hammock as we're walking, because the shoe's doing the work for you. So those things tend to work well. One of the studies, full-length insoles combined with a rockered shoe, gave pretty decent results. But again, like with any research, there was a lot of conflicting data, and there's just not one, way to skin it. And we were talking about this offline as we're starting. There's so many different causes to what's actually causing the plantar fasciitis or the plantar fasciitis, if it's if it's more inflammatory rather than degenerative, that's occurring. So what's causing that? Is it acute? Is it chronic? Has it been occurring over a long period of time? I've woken up a couple mornings and had, pain with the first couple steps and stuff like that, but then I'm fine like most of the rest of the time and most of the rest of my life. I don't think I had plantar fasciitis, so maybe I was getting a little tug on it. Or maybe I had plantar fasciitis, but just temporary
You
sort of
have
thing there.
a slide there that shows the incidence of plantar fasciitis across the spectrum of like what the population. I think it was
Yeah,
something like
so
yeah.
10% are going to
Hmm.
experience some sort of
Hmm.
symptoms over over some portion of time of their lifetime. That's a lot of people,
Hmm.
as far as that, and it may even actually be greater than that. But
Hmm.
how long is that? And in my office, if you've had the pain, it's transient, you're only experiencing once in a while. Yeah, that's the fire warning shot that's gone over your head. Do we need to like go full blown and see you, for all these visits and stuff up front? Well, no, probably not. You just need some advice, um, and maybe some exercises, depending upon your foot type and stuff,
Hmm.
possibly some sort of short term support, and you do better. It's more the chronic cases that I think we're talking about here, and things that are lasting longer. If people have had the pain longer than 4 weeks, I consider that pretty much chronic at that point. And,
Hmm.
we really need to be super aggressive in our intervention so that this doesn't become a surgical case. Now, I don't know how it's been with you. I haven't seen a lot of great luck with people that where they've had their plantar fascia severed.
No,
Basically, they develop posterior tibial tendonitis after that because that attaches to everything on the bottom of the foot.
I will
Plantar
say
fascia
this
can't
though.
support it, but yeah.
Yeah, no, I agree with you. I will say this though. I've had many athletes that actually tear part of their plantar fascia,
Hmm.
not all three bands, part of it, and it's extremely painful. And sometimes, the best course of treatment for that is to have them to continue to play and
Oh yeah,
hopefully
and complete
re-rupture
the
the whole
tear.
thing.
Yep.
Re-rupture the whole. Now, again, from a structural standpoint, maybe not ideal, but from a pain management standpoint, night and day, night and day.
Well, right. And, the plantar fascia is somewhat important with the windlass mechanism. And the
Correct.
windlass mechanism helps us to resupinate our foot after we go through mid stance and we're at full pronation. It helps us to do that as we move forward, go into ankle dorsiflexion, and then forefoot rocker, where we're getting hallux dorsiflexion at that point, or forefoot dorsiflexion. That's going to tension that windlass. And if the plantar fascia is intact, it's going to help to push the arch back up, along with contralateral swing of the opposite leg, and the posterior compartment contracting, and things like that. So
Mm. Why don't we? I think we'd be remiss if we didn't talk about some of um, the other possible reasons other than plantar fasciopathy, the differential diagnoses that could also be considered when you're dealing with this. The first one that comes to me is like a Baxter's neuropathy, right?
mhm.
Baxter's nerve entrapment
Yep.
oftentimes can kind of lead you to believe that you have a plantar fascial issue. Um, what else do you tend to find to see as something to be aware of?
Yeah, so just to back up for a sec, so
Mm.
Baxter's neuropathy, what Scott's talking about here. So the tibial nerve comes down the back portion of your leg. It's going to come down around the medial malleolus, and it's going to come down and go into the bottom of the foot to innervate the musculature in the foot. It's a medial and a lateral branch. Baxter's nerve is a small branch off the medial branch that does the calcaneal fat pad and the medial calcaneal facet, not facet, sorry, tubercle, and
Tubercle.
that area in there. And we get entrapment there a lot of times muscularly between those. And that can be treated really well with like Graston, cross fiber
Hmm.
massage, or just a lot of times going in there with a golf ball or something like
Hmm.
that and working at it. But yeah, that's definitely in the differential. And I would say that's the fake out when they're not responding to the traditional stuff after just a couple visits. It's
Yep.
like, I really need to look at what am I doing wrong? I've changed the other factors. Nothing's changing here. So,
Hmm. Yeah, I agree. I agree. So let's talk a little bit about treatment. It's already been discussed a little bit, in terms of what the best way to kind of handle this. But in my hands, plantar fasciopathy is one of my favorite things to treat. And the reason I say that is because I think right off the bat, you can make a significant decrease or have a significant impact on a patient's pain um, immediately by implementing a couple of things. Like for me, um, a modified low die arch tape is something that I have done probably hundreds of thousands of times over my 25 years doing this, trying to get that to calm down and to support the foot and to gain not only to reduce pain but also to gain confidence of the patient that what we are doing is going to be successful. So if I could take a patient's pain via taping from an 8 to a 3, 8 to a 4, they're happy as can be, right? Now obviously you'd love to make it from an 8 to a 0, but maybe that's not always that possible. But if you can get their cut their pain in half that first time you see them, they only start thinking, oh my God, if I see this guy or girl a couple more times, what my pain's gonna be gone, right? And you get buy-in from that. And the thing about physical therapy and a lot of what we do, it's not immediate changes, right? Even with an orthotic, sometimes if you're gonna get a custom orthotic built, sometimes you may or may not walk out that clinic that first visit with that orthotic in hand. Maybe you'll have something temporarily made. But what I've found is that while I'm making a custom orthotic and waiting for it to kind of come in sometimes, doing some modified arch taping, modified low die arch taping, and I've had patients wear it literally for 5 days in a row without taking the stuff off. I wrap it with some Coban so it sticks to itself, so it can get wet. If they're worried about that, they can wrap it in Saran wrap or some plastic wrap and keep it dry. But they wear it for so long because they have relief that they haven't had in a long time. And it, like I said, it allows that tissue to rest, which promotes healing, which is a plus. It gets patient buy-in, which is again another plus, and allows them to do other things throughout their day that can also be beneficial, right? So I think there's so many positive things that we can do to impact our patients with this type of pathology right off the bat that for me it's an easy win. I don't know if you have had similar success or not, Ivo, with that.
I have, but before we go further for a sec, real briefly, Scott, like 30-second, one
Yep,
minute, explain how you're taping
sure.
as far as that goes, because we tape as well, but we use a modified figure eight that works well as well. So,
Yeah, so and this is probably a good video demonstration one of these days that we can bring in. But the way I like to do it is I'll set an anchor strip across the metatarsal heads to start with, and then I make a series. When I teach this, I make a series of either X's or teardrops. So two basic shapes. The teardrop shape is of two varieties. It can either start at the first, go up the medial arch, around the heel and come back to where I started. So that makes the teardrop shape. You can do the same thing on the fifth. So you start on the fifth, bring it down the lateral border of the foot, bring it around the arch and back to the fifth. The second variety is an X, where you start on the first, you go across the arch, you go around the heel and bring it to the fifth, or you can start on the fifth, bring it across the arch, around the heel, and back to the first. So depending on the size of the foot, so no joke, I had a size 20-foot athlete in my clinic on my table the other day. Um, it's a big foot.
yeah.
How I tape that foot is going to be quite different than how I tape maybe one of my gymnasts who has a size 4, right? So I might be able to get away with 2 teardrops and 2 X's with a size 4, and I might do 3 or 4 of each of those different. And again, the width of the tape will obviously play a factor in this too.
Mhm.
And then once I get those down and laid down, then I do what I call covering up, where I take a strip of tape and I work from distal to proximal, and I start on the lateral border. I wrap it under the arch and I lift up as I come medially, but I'm careful to not lift up too much distally. And I try to lift up more proximally in the region of the navicular bone. Because again, if you lift up too much on the distal portion of the first, what you end up doing is you're going to end up dropping the back part of the distal part of the arch where the navicular is, because that metatarsal is like a seesaw. You bring one side up, the other side goes down. So you want to be careful to make sure to lift more aggressively, more towards the heel than you are at the forefoot. So depending again on how wide the tape is, how big the foot is, I'll do a series of cover ups where I start distally, work all the way back towards the heel, and then I'll just cover it up after that, which is some basic, very light wrapping Coban that sticks to itself to make a nice kind of secure covering, so that again it can get wet and I don't have to worry about the tape peeling off.
That was like a New York minute.
Yeah.
Yeah, that was great. I just don't know how many people were familiar with that particular technique.
Yeah.
There's a lot of different taping techniques. There's the other one where you just basically anchor over the med heads, come back with a bunch of small strips. I just use a modified figure eight, starting under the navicular on the medial side, coming up around relatively tight. We make sure that it's super snug, and we do this for athletes during play. And then as soon
Yes.
as they're done, we take a shark and we take it off, because you are around the ankle. You have to go fairly firm, especially if you're using Leukotape, Resonus or something like that. And
Mm-hmm.
it's definitely not something they're going to want to keep on for a long period of time.
And you
We've
bring
had,
up a great point. I was
yep.
say you bring up a great point about doing it with competition. So the modified low die that I talked about is great if you have I have done it in soccer cleats. It's not the greatest. It can be snug depending on the athlete and how tight their boots are. Will play a factor. And again, if an athlete's already getting spatted, like some of my football guys are getting ankle taped, and then you can incorporate this into an ankle tape, so it's maybe not as bulky. But I've done a fair amount of navicular lifts with kinesio tape, which is a lot thinner and lighter, just to kind of give some added support there as well in the cases where support may not be as ideal as I'd like it to be, but it fits in the shoe a lot better.
Yeah, we'll take a piece of K tape, the wider K tape, cut 5 fingers on the
Yep.
edge of it, anchor it on the heel, bring it forward, and then I'll do a figure eight over the top of that with one around the front a lot of times during a competition. And it's pretty good until the foot starts to get sweaty and the tape starts to get
Yep.
all icky, and stuff like that. So taping is definitely a really good acute where you can make that difference.
Mm-hmm.
Longer term, what's been your experience? Like, we'll use a footbed a lot of times in the office, not necessarily an orthotic.
Mm-hmm.
We do cadence insoles quite a bit, but there's a couple others we've used as well. Pretty good results just as far as unloading that short term. And we'll tell people a lot of times, it's like, look, your foot's going to fatigue as the day goes on. Let's not use any kind of support first thing in the day. And then as you get to more middle of the day, noontime, put the support in at that point as your foot and your intrinsics start to fatigue. You're starting to
Yep.
get more soreness to sort of limit some of that micro trauma. So it's a form of, we'll call it insole therapy, but it's not necessarily a full blown custom,
Mm-hmm.
which, we've certainly done, but I don't always think is necessary. It really depends upon the
Yeah,
degree.
I like a lot of the over-the-counter customizable ones too that are heat
Yep.
moldable. So you can
Yep.
basically get a $40-$50 orthotic, heat mold it. Because that's the problem I think with a lot of over-the-counter devices and footbeds is that they work if it happens to align very nicely with that given person's foot, and if that foot is of a different shape than the footbed that you're putting it in, it may not be as beneficial. So one of those inserts that is heat moldable where you can kind of contour it a little bit, and I call it a customizable insert while keeping
Mhm.
the price down is a good alternative.
Yeah, I think as long as you have a heat gun and a really good pair of
Yep.
leather gloves, we pretty much heat. If it's plastic, you can't heat with carbon, of course, but if it's
Mm-hmm.
plastic, we can heat mold pretty much anything, even if it's not supposed to be heat moldable, to make that work for folks.
Yep.
What's been your experience? So we'll use laser a lot of times for acute inflammation to get that down. Sometimes pulsed ultrasound. We've used electrical therapies with limited utility. Acupuncture sometimes and needling, although I would have to say during acute, it doesn't work as well as it seems to for chronic. And we're not necessarily needling the plantar fascia. It's more like we're needling the lumbricals, we're needling the quadratus plantae, some of the intrinsic musculature around there. What's been your experience with, like, we'll just call them standard passive modalities and treatment?
So at the university where I work, we're fortunate to have a lot of that stuff, right?
Mhm.
So, and I'm also fortunate that all of my athletes have an athletic trainer that's with them pretty much, 24/7, for lack of a better way to describe it. So when I go in there and I treat my athletes, I tend to do a lot of I don't spend a lot of time doing a lot of the passive modalities,
Mhm.
but I will, but they get them done. And the athletic trainers do a lot of that stuff. That's kind of how we designate kind of some of the duties. So, whether it be laser, we do a lot of shockwave
Mhm.
stuff,
Yep.
especially to the plantar fascia, as the medial tubercle area, that kind of stuff. A lot of great results with that. Um, we have the Hivamat. We don't use it so much for the plantar fasciopathies, but definitely laser, definitely the shockwave, definitely needling. Those are the big ones I'd say we use.
Yeah. Yeah. How about as far as, this article talked about it, and it was nice to see it in a positive light, but a rocker bottom shoe, but not
Mm-hmm.
necessarily a traditional rocker bottom shoe like, you think of a typical Hoka Speed Goat or
Mm-hmm.
Ultra Olympus where the rocker's in the front. What we find is some that have like the NBT shoe
Yeah.
and some of the Skechers that the entire
Yeah.
bottom of the shoe is rockered
Yeah.
works
Yeah.
really well. You'd think that, oh, the foot's going to hammock, but it just the shoe is rockered, not the foot inside,
Mm-hmm.
inside. But that seems to work well, especially if the shoe has kind of a rounded heel and allows for better heel entry as they're starting to come down rather than sort of a squared off heel that you see in a running
I
shoe.
tend to
So
find,
they get more heel rocker. Yeah.
I love that. I tend to find that that works better, in my opinion, with more of the rigid variety of the plantar
Hmm.
fasciopathy,
Hmm.
because if you have a more hypermobile foot, regardless
Right.
of the rocker, as you weight bear through it, your arch is still
Right.
going to collapse and there's still going to be added stress to it. So, yeah, I have had results with that, and we see it when people get put in rocker boots, right? Same idea. Those big rocker boots, those post surgical boots. They're not a traditional rocker like you would see in a sneaker, but um, I think oftentimes I think they're too bulky and not worth it half the time, because again, I think that the actual arch that's inside that boot is still being negatively affected by the actual weight bearing status of the foot in it.
Yeah, I was talking more about rockered shoes, and
Yeah. I
most,
know. Yeah.
yeah,
Hmm.
yeah, most rockered shoes, at least the ones that we've seen and that we sell here at the office, everything is pretty burly. So
Hmm.
um, it's not like if you are an overpronator, it's basically a motion control shoe because it has a lot
Hmm.
of torsional rigidity to it. So we will have a tendency to use them with both of those sets of folks, as
Hmm.
far as when they're coming in and doing that. In addition to, um, you know usually some sort of exercise. And with the exercise, you get the benefit not only of you're strengthening the foot, but what you're doing is you're getting increased mechanoreception from those muscles. So you're getting muscle spindle afferent activity, GTO activity, as
Yep.
well as joint mechanoreceptor afferents, all of which can inhibit pain at the spinal cord level, as well as through central mechanisms going up back to the brain and back down, plus the proprioceptive benefit. And if we can activate more mechanoreceptors and proprioceptors, generally are going to squash down pain to a larger degree, more through that dorsal column pathway, and some of the afferents, but spinocerebellar is going to do more muscle spindles and stuff like that. But we see that. So the benefit there, like everybody gets balance exercises pretty much,
Hmm.
when you're in the office,
Yep.
when you've got that kind of stuff going on. So, and it was interesting too. This paper didn't talk at all about any kind of exercise therapy, um, combined with plantar fasciitis, and I think that's and when you look in the literature, there's just not a lot out there, talking
Hmm.
about exercises specifically or exercise alone for plantar fasciitis. A lot of it is more physical intervention. At least that's what I found so far. So.
Yeah, no, I agree, and just like anything else, it's and I say this probably in every one of these that we do. It's for me, it's really simple. It's tissue capacity versus tissue stress, and if we can somehow offload the stress by making the tissue capable of taking over for that and being better able to handle it, then we're gonna be okay. So the stronger we can make the foot, the more stable we can make the foot, except in the case where, like we said, there's too much rigidity and we got to get movement. But even if you get movement, you've got to be able to stabilize through that movement. So if you just work on getting dorsiflexion, that's only half the battle. Now you got to be able to be strong through that new range, and that's where the strengthening comes in.
Yeah. And then in backing up just for a sec, because we kind of cut it short after Baxter's neuropathy, but other things in your differential diagnosis is what you're seeing. Is it even plantar fasciitis?
Correct.
So you can see people with basically, it's weird, but it happens, certain peroneal tendinopathies as they're coming across, especially with peroneal longus,
Longest.
as it's coming down across the bottom of the foot and attaching to the base of the first. Avulsions. We saw a gal who was a motocross rider that came in with raging plantar fascial pain. She had torn her tibialis posterior off of several of the
Mm-hmm.
bones on the bottom part. She had, basically missed a whoop and her foot
Mm-hmm.
went into it. But other things,
Tibialis posterior tendinopathy.
exactly, but not in the typical location, just above the
Correct.
medial malleolus, down in
Correct.
the bottom of the foot. People with really small and weakened foot intrinsics. So we
Mm-hmm.
do a lot of ultrasound, diagnostic ultrasound in the office, and you can measure that layer. Like if you know what you're looking for, you can measure the layer, and we look at it, or you can see it on MR a lot of times. It's like, oh, well, it's like, well, look at the thinness of the layers. Like you don't have any muscles on the bottom of your feet. It's like, well, there's part of the problem. You have no support, and yeah, you have plantar foot pain on the plantar surface, but it's not plantar fasciitis. Plantar plate tears is
Yeah.
another
Good,
thing
good one. Mhm.
that we see, and then plantar fasciitis. Everybody assumes it's in the heel, but it can be anywhere along that plantar fascia, all the way up to the toes, in
Correct.
that area where you can have a rent or some kind of a fascial disturbance.
What I find also with that too, that you're exactly right, and I think when it's at its worst, I think you tend to see it more spread more distally. But once you're able, it's almost like back pain, right? The goal when it's a ridiculous pain, it's bad, right? But sometimes the goal is to get it, even if the pain increases, to centralize it. Same
Yep.
type of thing with plantar fasciopathy. It may be that you notice it more distally to begin with, and as it gets better, the pain may intensify, but it may localize back to that medial tubercle a little bit. So I think something to think about there. Abductor hallucis tendinopathy is another one that sometimes on
Mhm.
that medial band, sometimes people get confused with. Um, so I think there's a couple of them. The classic symptoms, though, I would say that helps differentiate it is that those first painful steps in the morning are
Mhm.
usually the telltale sign. Usually, not always, but that's probably the go-to one.
Yeah, pain that gets better and then gets worse. So
Yes,
it's first couple steps suck, then the day gets better, and then by mid-afternoon they got to get off their feet,
I agree,
because of that fatigue, and then they're getting that discomfort down on the bottom there.
100%, hundred
Awesome.
percent. Well, this was fun.
Yeah, yeah. I think this was good. Hopefully, people got a little bit of an idea um, about just some other ideas, possibly, or some other ideologies. Maybe you learned a little bit about the plantar fascia. Maybe you learned a little bit about treatment modalities that could potentially help and work for you. So,
Mhm. Awesome. Well, guys, again, this video will be up on our YouTube channel. If you're not watching it live, if you're watching it live, great. Thank you very much. And again, come check us out at thegategeeks.com or our Instagram page, The Gate Geeks. So until next time, thanks everyone.
take care.